Right. Hi, everyone. So we just started the webinar. I'm going to give folks a minute or so to trickle in, and then we'll go ahead and get started. All right. So I think as folks are kind of trickling in, I can give an introduction. So first off, my name is Alex Weigard. I am an assistant professor at the University of Michigan Department of Psychiatry, and along with several of my colleagues, run this UMatt's Lunch and Learn talk series. So I want to welcome everybody to the November edition of the Lunch and Learn. So this series is a bi-monthly lecture that's hosted by the University of Michigan Addiction Treatment Services with the aim of informing and enhancing clinical practice through the exploration of topics that are related to etiology, prevention, and treatment of problematic substance use and of substance use disorders. So before we start, I want to point out that links to record your attendance for continuing education credits are going to be pasted in the chat. So if you're a social worker or physician who is trying to count those credits, please look out for those links in the chat. Just fill out the survey there. In addition to those links, we're also going to be sharing an evaluation survey in the chat. And this is a survey about your perception of the talk today, how helpful it was. And I would really encourage everyone to fill out this brief survey as well, because surveys like this really help us think about how to improve this lecture series moving forward. So I'll remind everybody about that at the end. And now it's my pleasure to introduce our speaker for today, Dr. Courtney Bagge. She is an assistant professor of psychiatry at the University of Michigan, as well as an investigator at the Department of Veterans Affairs Center for Clinical Management Research and the VA Ann Arbor Healthcare System. So she's a clinical psychologist whose research aims to better understand causes and treatment of suicidal behaviors with a focus on identifying near-term risk factors that can help clinicians understand exactly when an individual might be at heightened risk for suicide. So relevant to the goal of the UMatt series, her talk today is going to focus heavily on substance use as one of these really important near-term risk factors to keep in mind. Dr. Bagge frequently serves as an expert on national and international work groups, including those from the World Health Organization that are aimed at preventing suicide risk and improving the prediction of imminent risk for suicidal behaviors. And she was the 2017 recipient of the American Association for Suicidology's Edwin S. Scheinman Award for outstanding contributions to that field. So we are very lucky to have her today and very interested in her talk. So welcome, Dr. Bagge, and looking forward to hearing what you have to say.
Hey, let me just try to get my slides here. Can you see my slides?
I cannot at this point.
Okay. Let's do this. And I'm going to share.
It's great.
You see that? Okay. So I'm going to be looking over here. My slides are over here. Thank you so much for inviting me to talk. As you know, Alex said, I'm an associate professor here at University of Michigan, and I also do clinical work at the VA side. So my hope today is that we talk a little bit about some of the research strategies that I use and how that can be used in clinical work and vice versa to make it more of a practical application. Okay. Okay, so the objectives today is to briefly review research evidence on the relation between acute alcohol use and suicide attempts, and then to present clinical strategies for assessing the role of alcohol within a suicide attempt. I also want to then discuss ways to incorporate that info into your practice. So develop a tailored distress coping plan, which is like a suicide safety plan, and I'll go into those specifics. I'd like to acknowledge some grant support and that I have presented portions of this talk at previous conferences. So alcohol involvement is one of the main risk factors for suicidal behavior. And it has two dimensions. So we have the chronic use, which is alcohol use disorders, unusual patterns, problematic use. But we also have acute alcohol use. And this is used during a specific instance, a specific time period, let's say within a couple of hours. And both increase odds for suicide attempt. Now, they're correlated, but not the same construct. And this is important because not everyone who drinks alcohol prior to a suicide attempt is going to have an alcohol use disorder. And not everyone who has an alcohol use disorder drinks prior to their suicide attempt. There's actually divergent proposed mechanisms in how alcohol involvement could come to an attempt. So for instance, for alcohol use disorder, how that might lead to an attempt is that having that disorder can drive the social network, so cause problems with friends and family. It could accompany a comorbid diagnosis of depression, and that could then lead to an attempt. But acute alcohol use, we're really talking about in the moment. So we know when you're distressed, and I'll talk a little bit about this in a minute, that and in drinking, it can actually increase the distress, and it can really kind of narrow your focus on what is going on in your environment. If you're distressed, it's usually something bad. So how I like to think of this is who versus when. So when we're thinking about an alcohol use disorder, we're thinking about what group is at increased risk compared to another group. When we're talking about AAU or acute alcohol use, we're thinking about when someone is at increased risk. So the timing of attempt. Now, I would argue if we're thinking about imminent risk, our interest is not just who, but when. We already know that individuals who have a mental health diagnosis are at increased risk for suicide. So one of the things that we want to know is our individual patients. So when would they be at increased risk? So why did a patient attempt today compared to a previous day where they were also at high risk compared to all the risk factors they had, but didn't attempt? And I would argue that's really the ultimate question. In order to understand this, we need to have some kind of assessment to look at changes within hours in a day, and then also a within-person design, so we can look at changes within our patients. I developed the timeline follow-back for suicide attempts. Some of you might be aware of the timeline follow-back for alcohol use, where you kind of recreate, maybe over a year period about whether you drank or not and how much you drank on a specific day. Well, because suicide attempts is a relatively low base rate phenomenon, I've applied this to look at the 48 hours prior to a suicide attempt. This is with individuals who had to present to the hospital within those 48 hours. So this will enhance recall. And what you do is you look at kind of where they were, who they were with, what activities they did, and you kind of map it out. And then looking at things like substance use when they were drinking, how much they were drinking. Oh, this is when you got in a fight with your romantic partner. But you also look at how ideation might fluctuate over that time period, and also different affective responses and cognitive responses, like maybe, for instance, feeling a burden or hostility. The second thing we need is a within-person design. And so lucky for us, we actually have a design that was used, and developed in public health to look at imminent risk factors for a heart attack. Also a low base rate, relatively phenomenon, to be able to capture what transpired right before it. So instead of looking at two groups of individuals, those who had heart attacks and those who didn't, they look at time periods. What did the 6 hours prior to their heart attack look like, the case period, and then the matching 6 hours, maybe the day before. And that is the approach that we're going to be using. So you're really looking at changes within an individual. Okay. So this is one of the very first studies I did, and it's been replicated a number of times. But you can see here, here's the format where you have the 6 hours on the case day and the 6 hours the day before. And an adjusted odds ratio, so you're 6 times greater odds of attempting suicide soon after drinking any alcohol. And again, this is a sample of attempters, and we're looking at the period before their attempt and the period the day before. And this is because if we think alcohol is a warning sign or acute risk factor, I use those interchangeably for suicide attempt, they should occur more often on the 6 hours prior to the attempt than the 6 hours the day before. And this is adjusted for other drug use, negative life events. Here is just to show you that the more you drink, the higher risk to have a suicide attempt soon after that drinking. Okay, so we talked about that acute alcohol use, it's a warning sign and near-term risk factor for suicide attempts. But how do we get there? So lucky for us, there has been 50 years of research about what happens to you acutely when you drink alcohol. And so one of the things that we know from laboratory studies, survey research, is that if you are drinking and you are distressed, okay, so you're distressed, maybe you're drinking to cope, it's going to increase your dysphoria. And I'll show you in a next study that it will also, it looks like it increases the intensity of your suicide ideation. Now, alcohol myopia, this is when, again, you're in a distress and you're focusing on that distress. You might have tunnel vision, right, on what's in front of you. And you have less access to things that, might inhibit a suicide attempt or a decision to drink and drive. So for instance, with suicide, it might be like reasons for living. You're not able to access that in the moment. We also know that it lowers response inhibition. So alcohol, it increases the likelihood of extreme behaviors like violence and drunk driving and perhaps a suicide attempt. So this is just going to be a quick reference to how this next study showed that acute alcohol use increases the intensity of suicide ideation within individuals prior to a suicide attempt. So what's nice with the timeline follow back is you can outline these hours, these 48 hours, as you would as a panel design. It's retrospective. I want to just highlight that. But it is temporal as far as how you work with the participant. So what you can do is you can look to see how these exposures or alcohol, drug, negative life events predict the intensity of ideation in the next hour, controlling for the previous hour. And what this is just to show you is that this alcohol use is, if you look at the very right-hand corner of the lagged, is that this is something that is associated with intensification of suicide ideation in the next hour, even controlling for the prior hour. We didn't find something for drug use. That's because we had to collapse across all drugs. We know the problems with that, given different CNS stimulants and depressant effects. And then also negative life events. We saw that also intensified. Oops. Okay, so what are the broad clinical implications here? Well, when we're thinking about a warning sign, we want to have education about like, okay, drinking can be something. If people are increasing their drinking, that can be a warning sign for suicide attempt. It's not just to predict, but to prepare. So getting that information, that's why SAMHSA and a lot of different agencies has lists of warning signs to look over, and alcohol is included. And to remember that every clinical encounter, whether it's in the ED, coming to your office, is a teachable moment. So that might be that you've noticed that they are drinking and it's kind of escalating, and you can inform about how alcohol might interact with those emotions for these high-risk periods. So when I was describing kind of the acute effects of alcohol. And broadly, what we would want to do is take alcohol and we want to acknowledge it for the patient that this is a warning sign and to devise a suicide safety plan in order to look at what are some coping strategies that they could enact in to prevent suicide. Now, I do work at the VA, and a suicide safety plan is required. And I believe it's also required at the University of Michigan. I don't practice right now. I don't have a clinical load at the University of Michigan. So I'm not going to go into the specifics of a suicide safety plan. What I want to do is just to briefly review it and then provide tools that will help really determine what the role of alcohol is and how you can kind of incorporate different strategies while still fulfilling the requirements of having a suicide safety plan. So these are more tools to enhance the patient's experience and also the veracity of your plan. So take a step back. Perspectives underlying the plan is that we know that suicide risk fluctuates over time. So people are not going to attempt while they're in your office. They're going to be outside of your office, usually late at night, perhaps, and they need something to kind of reference back, because in that moment, it's really, really hard to think about, oh, what are we going to do? So suicide safety plan is, the perspective is kind of like stop, drop, and roll. It's over practice. When you're in a fire, you're like, what should I do? Well, here you've already kind of trying to determine how to cope with that. And it's very consistent with CBT approaches to any kind of behavior change, where you look at antecedents, consequences, what some alternative coping strategies. Okay, so a safety plan is a standalone brief intervention. It's usually just one session, and you provide those experiencing a suicide crisis with a written list of, you work very collaboratively, but you determine what their warning signs are, alcohol. And also then you have a written list of different concrete coping strategies that you work with the participant to write. And it's on a one-page form. And this is suggested as best practices. Now, the thing that is not talked about, which is an inherent part of the suicide planning intervention, the safety plan, is that you're supposed to obtain a narrative of the crisis. So the suicide crisis, talking to them about, okay, what happened, before that led up to this, not, back to childhood or even a month before, but really in this kind of chain of events. So this might be 6 hours prior to their attempt. And then during what happened and after the crisis, what thoughts they were, what events, what behaviors, what they were feeling in their body. These are all types of warning signs. And this is supposed to be intended to inform you working with the patient, to identify your warning signs and then also some different solutions. This is what it looks like traditionally. I just want to show this just to make sure that everyone is on the same page. Okay, so suicide safety plan steps. One is recognize your warning signs, and then it goes into, usually it's asked like, when do you think you should be using, looking at this plan for, like, how would you know that you might be getting into a crisis? And then you write them down. And then, okay, what are some things that you can do on your own? So the internal coping strategies. Then what are some things that you can do, like going somewhere for distraction, or contacting people just for distraction. And step 4, who can you contact to let them know you need help? That is a non-professional. And then it's contacting professionals, including, the crisis line. And then step 6 is make the environment safe, which we're not going to go over today. Now, inherently, we all know that warning signs are not linear. So what I mean by that is that there might be a warning sign that your patient has, and you directly say, call the crisis line. The suicide safety plan, as far as the template, is not set up that way. And a lot of times there's not trainings, or providers don't even know about how to determine what is a warning sign for a particular patient. So I'm going to give an example of something that I did with a patient that is based on empirical strategies that you might find hopefully that you find helpful. Then I will talk about how you can then incorporate that into the traditional safety plan. So this is the role of acute alcohol use within a single patient. What I did is I modified my timeline follow back by looking at the last 6 hours. And it's very personalized to ask about thoughts and behaviors, emotions, physical sensations. And this is very consistent with chain analysis and dialectical behavioral therapy, where you really are exhaustively kind of going through the chain of events up into your suicide attempt and after, but I will just be presenting up until the attempt. And you can also incorporate it after you get good at it. At least for me, that was something that I had to do at a later time point, is to incorporate a motivational interviewing kind of stance while you're gathering this information. And this has the potential to facilitate the identification of warning signs. And then also you can pair a specific warning sign with a specific coping strategy. Okay, so here's an example. So let me orient you to this. First, we have a situation at the top, and the bubble is kind of what this patient said that her thoughts were. The timelines at the bottom from 4 to 10, and here are kind of my go-to that are typical prior to a suicide attempt. So anger, shame, sadness, tension in your body. I usually just have a piece of paper and I just kind of jot those down and say, okay, where did this start? Your suicide crisis. And they usually go right to when they took the pills and say, okay, let's back up a little bit. And that doesn't mean that you can't add different emotions or different, physical feelings, but this is just an example of how you might dance with the patient. So the situation, my patient spent the night with her ex. Her partner said that he missed her. And that they were going to spend the day together. And so she was very hopeful. Now, this black box here is something that the therapist might say using a motivational interviewing. So at this point, I would say to my patient, okay, then what happened? What was the next thing that happened? Okay, well, my ex said that, he had no intention of getting back together. That, and I said, what were you thinking? He's such a jerk. Sounds like it. Acknowledging that. And then okay, what was going on in your body? Oh, I had lots of tension in my shoulders. Okay. And what about these different emotions? Yes, I was extremely angry. Understood. And I probably point out, look at how anger and tension both went up. And I was using a 0 to 5 scale. Then what was the situation? Well, she went into the bedroom and closed the door. She wanted to hide. So he doesn't care about me. I want my bed. And what the therapist could say is when you went into the bedroom, it sounds like you felt rejected and you just wanted to hide. And so here you can see she went in there, her anger goes down, her sadness goes up, and her tension really kind of tracks the anger. Okay. Then what happened? Well, the situation was she started thinking about drinking and finding alcohol. She said she doesn't want to think about him. I can't stand this. I know that drinking would help. Her sadness is even more increasing as she's thinking about how she's going to cope with this. And the therapist could say, how did you think drinking might change your thoughts and feelings? To help you escape him. So what happens is that this patient drank 2 beers. She actually started to have more positive, emotion as far as, less sadness, you can see, during these 2 beers. And, had some tension reduction. And the therapist says, you are feeling less sad, but it seems like your mind stayed fixed on him. And so that kind of myopia potentially was going on. And then what happened? Well, drank 3 more beers. She said that she, thought about she was an idiot. She doesn't, want to take this anymore and wanted to die. So at this point, she had 5 beers, and you can see the shame goes up, the sadness goes up. And for this particular patient, the suicide ideation and shame tracked 100%. So, and the more you drank, the worse you actually felt about yourself. You had a lot of shame, so much that you thought about suicide. And then the last one was she took a handful of pain medications and she drank it with a beer. Here's some of the thoughts. And the therapist said at that moment, it was hard to think of any reasons to live or other solutions, but to kill yourself, really kind of setting up for psychoeducation about alcohol and those effects. Okay. I know that I'm going really fast. I just want to make sure that you have the materials that I discuss some of the different strategies. So you have that. Then this is key, is you identify coping strategies. And this is like a solution-focused analysis for dialectical behavioral therapy. Okay, so here is our timeline. And really these are key ones that the therapist said, and also that I want to kind of cue my patient. So there was frustration and tension. There was rejection and hide, wanting to escape, felt shame, intense suicide ideation, and then felt like there was nothing that she could do. So at this point is when you then kind of review it and you say, gosh, okay, so when you're angry and your tension, like when this happened, obviously this was not expected, you know, you were angry. What is something that you could do at this point? And you work together to fit that particular time point. So reduced tension might be one, progressive muscle relaxation, deep breathing. And these are just ideas as an example. Okay, when you wanted to go and hide, what are some things you can do? Maybe opposite to motion action, get out of the house, go for a walk, go to a public place, maybe distract then, like we were saying, with people and settings. When you wanted to drink, right? You just wanted to just escape. Well, maybe you use more intense distraction, like intense gaming that really gets your mind going. Or, you know, use up the energy with exercise, take a cold shower, use maybe some of those tip skills if you're familiar with DBT, or reach out to others so you can get outside of your head. And then when this patient, you know, felt intense shame and suicide ideation, it really, given previous circumstances, had made an attempt a long time ago in a very similar situation. And when they feel shame, a spike in shame, this is when they should be calling their therapist or, you know, the suicide crisis line and seek emergency help. Okay. So looking at the potential benefits of reviewing that narrative in a somewhat more structured way, the process itself is likely beneficial because it's going to help enhance what their memory was going through this. It also, people feel the emotion going up in a safe environment, so it will also go down. They have more knowledge of kind of how these relations work, and it can inform a suicide safety plan. Okay, so let's go back. Here's our timeline. Here's different coping strategies that we came up with. And this is how it would look like on a suicide safety plan. You see, it's not linear. So at each point of these, there's always things that the person can do. And then as it went, there was different levels of intensity you can think of. So it really is like this, where a particular warning sign is paired with a strategy, and that may not go in this linear format. And I know that the developers of the suicide safety plan recognize this and, you know, have said that we have to have this narrative in order to do that. Unfortunately, the current plan is not as easy to indicate which warning signs go with what response options. So I developed this form that may or may not be helpful to you all. And I call it the pattern form. And this is something that you could fill out the traditional suicide safety plan, because I know that that goes into an electronic record as is, but this would help the patient where you can look at these signs and you can have them up in kind of level of intensity of a coping response. So for instance, low intensity, PMR, breathing, maybe watching TV as a distraction, moderate, is getting more active. And you can see right here, or distracting by settings, this corresponds step one, step three with the suicide safety plan. High, well, this is where usually you want to, reach out for help, but you can still use internal coping strategies. So non-professional, and here's a professional. Here is unhelpful strategies. So we have warning signs, can be thoughts, behaviors, emotions, cognition, or I guess that's the same thing as thoughts, physical sensations. We could also put here, like instead of hiding, right? Here's the signs, here's what you do. Or instead of drinking. All to say is this is a pictorial. I'm going to have kind of the host for this send out this document where I actually have it so it's blank, one that's blank and one with instructions if you want to try it out. But you could go over this with your patient and then give your patient this as kind of a summary. And this is just to show how what the warning signs form traditionally looks like. Now, if you don't want to use that and you're like, I'm just going to fill out this form, I'll try to do my best with pairing. I want to offer you another tool that I developed. Because people just went through their suicide crisis with you, then I find that patients have a hard time thinking, well, what is some things I could do on my own, right? Or where could I go? Or who are the people I can ask for help? So what I am going to send to you is I made a list of different warning signs that are typical that you could present to the patient, so they're not starting from scratch. They can kind of look over it. The same thing with internal coping strategies that they may not have thought of, or you might not have thought of, that could be applicable to a specific warning sign. So this is what I was saying: lists of warning signs, examples, internal coping strategies, like do one thing to make you feel accomplished during that time. Changing body temperature. This could be also a great way to explain kind of the dive reflex and how we can maybe change our mood by changing our body. Lists of people to provide distraction. And then I think this is important that we don't think of is having something that is open 24 hours that you suggest. In the South, it used to be Waffle House. I'm not sure what it would be here specifically, but that is always helpful because then they could go out of their house during those times where other things would be closed. And this is an example just of some of the warning signs where I blew up that you will be receiving if you want them. Okay. So one thing I want to stress here is that at the VA, it's required to do a suicide safety plan if someone hits a certain threshold of their suicidality. I call what I've developed a distress coping plan. So it doesn't have to rely on even having a suicidal crisis. It could be the most intense moment that they had, they were distressed when they came to your office. And then going through that and getting different scenario or different coping strategies that they could use, going forward, paired with these warning signs for this intense distress. And the reason why that they may never come back to our offices. We don't know, and so at least then they have something going forward. And I think it's really important because ideation fluctuates. Research that I've conducted and others has shown that actually, if you look at the week prior to a suicide attempt, so we know ideation fluctuates over time, and that's the time usually where you're looking at outpatient, visits is a week, is that 42% said they didn't even have any kind of suicidal thoughts into the 3 hours prior to their attempt in that week prior. They might have left their office and I'm not thinking about it. And then 3 hours prior to that, 6.5 days later, let's say, 68% said hadn't even thought about a method or any of the planning components. And 85% said they didn't decide to attempt until the 3 hours prior to the attempt. So this is why I think that it's important to consider having a distress coping plan And it could be used, urges to use substances. It doesn't even have to do with suicide. Or emergence and distress, what you can do, or intensification of suicide ideation. And it's just an adaptation of the suicide planning intervention that I showed you before, but making it more global. I'd like to acknowledge my patients who have attempted suicide and participated in my studies, and then also my clinical patients who I've learned so much from. My research personnel, you know, there's been hundreds over all these years. And right now it is Sarah Cohen and Sarah Yan and Elizabeth Barber that I want to thank, as well as Laura Schur, my collaborators, and also the funding agencies. And that's all I have. So I'm going to stop sharing.
All right, thank you very much, Courtney, for that talk. A lot of really great pragmatic information there for clinicians and everyone else. So we're going to open it up to questions. So if folks have any questions that they would like to put in the chat or use the Q&A function, we can discuss those. As folks are doing that, I want to point everyone's attention to the chat where we have the links for, we have two links. One of them is for a Google form that allows you to evaluate the talk, as well as, if you are a social worker, claim CE credit. I would encourage everyone, even if you're not a social worker, to please fill out the survey. Like I said, this really helps us improve the series as we move forward. And if you are not a social worker and you do the survey, I would suggest that under the field for social work license number, if you could just report your profession, right? Like if you're a psychologist, physician, etc. So yeah, and then the second link, of course, is for physicians looking for continuing education credit. Yeah, so does anybody have any questions or questions or comments about the talk?
Alex?
Yeah.
I can't see if there's any questions. I just wanted to let you know. Do you mind if I talk a little bit about the materials? Okay.
Yeah, no, absolutely. Please. Yeah, so we're not seeing any questions in the chat right now, so please go ahead.
Okay. Awesome. So I developed these materials, which are just to enhance the patient's experience and then also your experience in doing this. And I wanted to leave time for questions because this is my favorite part, is to be able to take what I've learned in research that I've applied clinically and vice versa to give back ideas and thoughts to others, and also to get back ideas and thoughts. So if people are like, there's no way that I'd use that pattern form, feel free, if you don't want to, say it out loud here, to email me. My ultimate goal is to develop things that are helpful, for clinicians especially. And I will ask, I don't know if it will be Alex, someone to send out to anyone that is registered that pattern form, and then also the list of examples if you want to use it with your suicide safety plan. But I would love feedback, is what I'm saying, as far as if you try it, how it worked for you. I have given it to students before and colleagues, but and made a lot of different adaptations. But I would love to hear how it works, especially for this population. So.
So looks like we do have one question in the Q&A. Tips for doing all of this in time-limited sessions. That's a great question.
Yeah, so I'm not sure how the university works as far as the number of sessions. When I've worked at different clinics, I use this as my first session. So you have your intake, but this is my very first session is looking at a recent distress, creating a safety plan, setting the stage for that. And so if you have that, if it's allowable, like your pre-session to do that and then do your 12 sessions, I think that that is really important. Because what happens then is that usually you're not expecting it. Someone says, I'm having suicidal thoughts, and it triggers it. And then you have to, you know, use that session in order to create your safety plan. And it's kind of offloads it there versus kind of starting in that and then revisiting the suicide safety plan. So that's one way of doing it. If people want to just keep with the standard suicide safety plan form, they could literally just circle a warning sign and point to what kind of strategies they want. And that's how I started. And then I had patients take a picture of it. So it could be as easy as that, you know, as far as somehow using a narrative, right, of your choice to inform those warning signs. But maybe some of these strategies might be helpful to determine kind of what those warning signs are versus just asking the patient, kind of what are your warning signs, to work collaboratively in order to determine those.
Okay. I guess I had one question I was thinking of too. Which was that, can you speak a little bit to the role that ambivalence about substance use plays in this process, right? Because this is something that I think we deal with a lot as clinicians, right? For, working with a lot of patients with substance use disorders is, folks like, on the one hand, sort of recognizing that it's a problem, and on the other hand, sort of waffling a little bit on that. I guess how does that play a role in how you assess this sort of the stage of, I guess, the stage of change that a person is at, right? Whether they're sort of committed to the idea that this is a problem, or they're still sort of wavering on that.
Yeah, so I think that's an excellent question. So alcohol or a substance might not be a warning sign for a certain individual. If someone is hazardly drinking every day at the same amount, then that's not to say that we wouldn't want to target that and help that, but that might not be the one thing that we notice that would trigger a suicide attempt. So I really want to highlight that, is that my goal when I do this is not to tell people, what kind of treatment they need. And so I'm doing it outside of that, right? It's more to establish kind of a safety plan or just a coping plan, right? So by doing something where it's a real event, even if it's not a suicidal crisis, but the last time they got distressed, they're coming in, maybe they're like, yeah, my drink is not a problem, it's arguing with my wife. And chaining that non-judgmentally, it could really have someone maybe move from that ambivalence to a different stage. That's not the goal for what I'm doing, but it could, I've seen that definitely happen. But I think just being factual and having people see and collaborative when you're doing it, oh, what were you thinking there? Oh gosh, look at how your mood went down. I mean, being a Columbo and a detective can be really powerful for patients. So I think it's sometimes independent, right? As far as what you're going to do then to recommend, treatment. This is more about a specific instance of distress. And yeah, maybe you then do it again. Then you do it again with a different one. And you can kind of start to see those patterns, but you're not saying, okay, this is an issue. You're having the repetitive actions. And for instance, dialectical behavioral therapy, one of their, they've done this with individuals who are who have substance use disorders. So there's a manual for that, as far as kind of how to handle that situation. But I don't want people to think of a patient who is hazardously drinking every day, that this necessarily is kind of the go-to, right? Because it might not be, as their family member notices they're drinking, that's why they attempted that day, right? As far as something you can notice, because they're always drinking, it's not a warning sign for that person. Doesn't mean it's not incredibly important, as you guys know, with my research on substances.
That's great. Yeah, and it really underscores the importance of establishing like what are the person's behavioral patterns in general, and then what's changing, right, from in a dynamic way. So no, that's great. So we have two more questions from the group. One of them is wondering whether these strategies work well across many cultures or whether they might require some kind of adaptation.
These are great, great questions. How I think about it, well, first of all, there has not been research about how you can do to my knowledge, a chain analysis, focusing it more on alcohol and the role across cultures, across different ages. And so there's a lack of research on diversity, and that's something that we really, really need. And the thing I can tell you, it's about the participant. You're asking what their thoughts are. You're asking what their behaviors are. You're asking what is kind of going on here. And as long as they are willing to ask those things or to tell you those things, then it should, you will have something to put on the paper. In some cultures, for instance, they will deny that. I'm thinking of a patient who had more somatic complaints during a distress chain, and emotions were like the same across. That's okay, because as clinicians, we don't have to say that we have to have these up and downs and this variability. You go with the patient is what I'm trying to say. And so if there's no emotions, as far as like, yep, I was a 5 across for positive and negative, then you go with what they can tell you about their feelings and experience. But as far as implementing this planning collaborative process in youth and teen populations, so one of my collaborators is Cheryl King, who also works in the teen suicide area, less with substances, but I do know that DBT and chain analysis has been used with a variety of different populations. It was developed to prevent suicide, but it has been used with substance use disorders in a variety of different ages. But we need more. We definitely need a cultural perspective into this kind of line of research. So I would love to hear people's ideas.
Yeah, so thanks for those questions. It doesn't seem like we have any additional questions at this time. I'll give folks just another minute to ask anything before we go. But as we're doing that, I just wanted to remind everyone again to look at those two links in the chat. The first one is an evaluation form that I've encouraged everyone to fill out, and that for folks who are social workers and doing this for continuing education, it is mandatory to fill out to get credit. Like I said, please. Okay. Oh, I'll double check that. Yeah. So I think, yeah, and sorry. Anyway, yeah, please do fill out that evaluation. It really helps us out. And then also, if you're a physician looking for CE, please go to that second link. I did want to point out, so I think you might have answered, I think you might have been answering this already, but there is a second question in the Q&A about ways to implement this with youth or teen populations. Is that I thought you might have touched on that a little bit in your last response. Is there anything else you'd like to add about that?
Yeah, so Cassie Glenn is a former student of mine and is an amazing researcher and clinician, and she specializes in teens. And I know that she has used this um, kind of framework as far as really trying to determine what the functional relationships are with teens. I don't know offhand any kind of publications or whatnot, but I know that it has been used with teens, and a lot of people that I respect um, have used it as well. So you just got to adapt. Basically, the main thing is you go where the patient goes. You can kind of guide maybe things you notice, but they're the experts on them, is kind of what the DBT stance would be as far as what they share.
Great. So I'm not seeing any more questions in the chat, so I think we probably go ahead and finish a few minutes early. But again, I do want to thank our speaker. Thank you so much, Courtney, for such a pragmatic talk and for being willing to share the resources that you've developed with everyone. So we'll definitely make sure that folks get access to those. So yeah, thanks very much for coming. I hope everybody found it helpful. And please do fill out the evaluations in the chat and reach out to us if you have any issues with that. I hope everyone has a great rest of your day.
Thank you very much for inviting me.
Our pleasure.